guys, welcome to the second part of introduction to manual therapy. We've had the first part in the last lecture, but because that's a bit long, I thought we could break it into two. In this introduction part, do not forget we are trying to define some terms, some terminologies that will be coming across in the course of doing our manual therapy. So this is the part B, a follow-up to the last presentation that we had. Now, sometimes manual therapy could be said to be a general technique or a specific technique. When do we say that manual therapy is a general technique? When the force is directed to number of joints that has been confirmed to be hypermobile, all right? Not only one joint. When the force is directed to a number of joints that has been confirmed to be what? Hypomobile. So the force that the therapist is applying is not specific to only one joint. It's specific, it's going to affect different joints in the body. You can see from the diagram you have on the slide that the right knuckle of the therapist is doing posterior anterior glide right onto the mid-thoracic spine, and the left arm of that therapist is also stretching the shoulder joint from the posterior surface, from the inferior part of the axilla. So effort is being directed to the shoulder and to the mid-thoracic spine. So when the force is directed to number of joints, then the technique will be said to be hypomobile. The technique could be said to be general technique. The disadvantage of general technique is that sometimes you tend to affect a joint which is not hypomobile. The effort could also be touching some other joints in the body who are already hypermobile, and that will lead to continuous instability. So I hope that is clear. In general technique, the force is directed to number of joints, not just a specific joint. It's okay as long as it is only working on joints that are hypomobile, but the side effect of this technique is that sometimes the effort of the therapist could also be touching a joint which is relatively hypermobile, and that would lead to greater instability. Okay, now on slide number 3, you see the fingers of the therapist directed to below the spinous process of one of the vertebrae in the mid-thoracic spine. So all the effort of the therapist pushing upward and downward, that tick-tock thing I talked to you about in the last class. If it's going to deliver posterior anterior thrust, pushing downwardly, it's going to affect only that segment of the spine where a thumb is placed. So no other joints will be affected at the same time. So such a technique is said to be specific. So in specific technique, effort is located to a specific joint, and the uninvolved joint is not involved. The unaffected joint is not involved to any reasonable extent. Then I also would like to introduce you to the concept of physiologic barrier and anatomic barrier. Now, normally, when you ask a patient to do active range of motion, the patient will be able to move to an extent and then stop. For example, if you ask me to rotate my neck towards my right shoulder, I can only go thus far and stop. What is stopping me? The bones, the muscles. What is stopping my movement from going any further? It's got to be the muscles, the tendon, the ligament, because they've reached their elastic limits and I can't stretch them any further. So I have reached a barrier of movement called physiologic barrier. Physiologic barrier usually come at the end of active movement. Do you understand? And the barrier is normally constituted by structures like muscle, tendon, and ligament. But normally, when you now ask a physiotherapist to come and do passive movement on my neck, the same movement, rotation to the right hand side, now the physiotherapist might be able to go further than I did initially. Why? Because of the effort coming from the physiotherapist, But eventually, physiotherapy will not be able to turn my neck 360 degree. The physiotherapy will still witness a barrier in the course of him doing that movement. So what is causing the second barrier? The second barrier is set in by bones in the joint. It's mainly constituted by bone in the joint along with the other soft tissues in physiologic barrier. So this second barrier is actually called the anatomic barrier. All right. Anatomic barrier is the point at the voluntary range of motion of the joint that is limited by bone and soft tissue, whereas physiologic barrier is limited by soft tissues like muscle, tendons, and ligaments. So normally, when there's no injury to any part of the body or to any joints in the body, we all have normal physiologic barrier. That is, we can turn as much as we are supposed to turn. But whenever there is injury to any part of our body that is causing pain and movement limitation, then eventually our physiologic barrier becomes very limited. All right, it's reduced. And when we now seek for help in terms of manual therapy, then the physiotherapists or the manual therapists will come there and carry out passive movement, carry out mobilization, and maybe manipulation with the intention of taking our reduced physiologic barrier back to normal. Do you understand? You know, the injury has reduced the physiological barrier. And in the course of doing their work, sometimes in the course of achieving restoration of the normal physiologic barrier, sometimes they even move that part of our body to anatomic barrier repeatedly before we'll be able to restore the pre-injury physiologic barrier. I hope that is very clear. Now, another term I want to introduce us to is the concept of pop sound. Pop sound, the sound, cracking sound that usually come with thrust, with manipulation, not with mobilization. Now, sometimes when manipulation is delivered on certain joints in the body, mark my word, manipulation, you can call it manipulation, you can call it thrust, you can call it high velocity, low amplitude movement. Sometimes when it is delivered on certain part of the body, it comes with sound. This sound could be associated with a sense of relief by the patient. You know, when this sound is produced, few patients reported pain relieved, they reported feeling good, they reported movement restoration. But what we are concerned about this morning is what causes that sound. What's the significance of that sound? And if that sound is not produced, does it mean we have not done manipulation the way we ought to have done it? That's what we are bothered about. All right. The pop sound is believed to be associated with formation and breakage of cavitation inside the joints. Now, let me break it down. You know, many of the joints in the body are synovial joints, isn't it? And as synovial joint, they have synovial fluid inside them. And inside the fluid, we also have some dissolved gases, particularly carbon dioxide. So when we're doing manipulation, just like I illustrated to you in the last class, you've got to move the joint to lock the joint. You've got to move the joint to take off the slack. At that point, when you lock the joint or you take off the slack, you are exerting a lot of pressure on the content of the joint, including the gas. And when the pressure is increased on the dissolved gases in the joint, the volume of the dissolved gases will reduce. You still remember the Boyle's law that pressure and volume are inversely proportional. So when you lock the joint and you reduce the pressure, the gas formed within the synovial fluid will form cavitation, form like bubbles. They form cavitation, and the cavitation also do not stay for long, they get broken. So it's the formation and the breakage of the bubbles or the cavitation that is responsible for the formation of that pop sound. It's not just the grating of bone over bone. If it were to be grating of bone over bone, then we can just repeat the sound at any time that we so desired. But because it's the formation of cavitation and breaking of cavitation, and once a cavitation is broken, it took considerable minutes for the gas to get absorbed and for another cavitation to be formed. That is why you cannot get the cracking sound in the joints at a point and then you repeat it few seconds and get the sound again. No, it will take a bit of time before the sound will be able to be produced again. And on slide number 6, we're seeing some potential benefits associated with that pop sound. Increased joint range of motion. Some patients relieve that